Okay, I think I got YouTube going at the same time. Any other questions before we get going here? Every time I look up to see the class, I get blinded by the spotlights. Then I see spots. That's okay. Okay, we'll get going with this. Let me make this full screen. So we got about halfway through this chapter. We should wrap it up today, and then we'll start. What chapter is this? 23. We should start the next chapter. I think it's 24 on Friday. So we're doing good. We're a little bit ahead of the game, which I think is good. It's better to be ahead than behind. So we left off. We talked about some bacterial culprits, and now we want to think about a few viral pathogens, and then we'll talk about a couple of protozoal organisms as well, and some yeast. We need some fungi in there as well. Candida albicans, can't forget about that. So initially, we want to talk about herpes simplex virus. Really, we're thinking type 2. There are numerous herpes viruses, and we've mentioned briefly a couple. We talked about herpes simplex 1, that we think like cold sores, chickenpox, we call it varicella zoster. It is a type of herpes, different than cold sores or the genital herpes that we're going to focus on right now. So there's a lot of potentials when we think about these. The herpes simplex virus types 1 and type 2, we do think about specifics like cold sores with type 1 and genital lesions with type 2. But I believe I mentioned when we were talking about type 1, there are definitely potentials where you could have them in either potential with type 1 in the genital region or type 2 around the mouth, potentially, all right? So this image is an electron micrograph showing the herpes virus, these virons. We can see handfuls of them here. And now we'll shift over to the actual lesions. So there are all sorts of potentials with this, and this is something like type 1, where these virons can go dormant on nerve cells and flare back up later. Herpes is something that you never get rid of, all right? So definitely issues and concerns when we think about this. So typically we think about type 2 lesions on the genitals, but there are also potentials to see lesions, maybe not exactly looking the same, as we've got some of these circled here. I'm assuming we're looking at the groin area right here. So you can see it elsewhere on the skin or mucous membrane. And in these circumstances, these lesions may go undetected or overlooked, not thinking that it's the same stuff. That's a potential issue as well. Definitely some potentials for concern. Active lesions set the stage for being readily transmitted. And ultimately, when we think about herpes, there are issues. I shifted the slide, but I'm not ready to move over to that yet. There are issues with children potentially becoming infected with this. There are a couple of different possibilities. If that child during pregnancy, if that child happens to be growing in the womb and the mother becomes infected during pregnancy, the outcome for that developing child is very poor. If the mother already has it, and the child is developing then in transit through the birth canal, there's the potential for that child to become infected. Oftentimes thinking about maybe skin or eye or both as potentials for becoming infected. There are other circumstances where it may be systemic, may disseminate throughout the body, causing central nervous system damage and potential fatal consequences for that child. And it also can result in spontaneous abortion, stillbirth, things like that. And that might be more thinking the woman that contracts it during pregnancy as a greater likelihood of that as an outcome. So there are definitely other potentials with that, and even that child without seeing any of these lesions in transit through the birth canal can still become infected. Now we'll shift gears to some genital warts. What a way to start your Wednesday morning. Holy cow. These have the potential, and there are all sorts of papillomaviruses, human papillomaviruses, handfuls that cause, as we see here, genital warts. There are other types of papillomavirus, not thinking really genital warts, but the potentials for cancers, all sorts of possibilities. Typically thinking cervical cancer, but it's not just that. There are all sorts of possibilities. Kind of just depends on the circumstances with this, all right? There are potentials, as we see in these images, anal cancer, penile cancer, cervical, vulva, oral cancers, all sorts of possibilities. And again, it's a type. There are numerous types of papillomaviruses. And we'll hit here in a second and talk about some vaccine as we move through there. We'll think a little bit about that stuff. So you can see the growths with the papillomavirus in both circumstances. And I will shift over from that. Here we're looking at the papillomavirus, this through microscopy, coming out of a pap smear. As we look at this, we've got normal and non-normal cells. And initially, not knowing what you're looking at, you might not know that there's a difference with these guys in the first place, but there is, all right? And these are the same cells, cervical cells, but uninfected and infected. And you can see these guys over here quite a bit larger. The nuclei are a lot larger. There's some hyperchromasia, so you get this kind of stippling or different colors. I mean, it's still purplish with the stains we're using to get these, but there's variation within the nuclei, and you don't really see that in the normal cells, and also the larger size. Coleocytes are what we call these guys as we see them, and it is HPV infected cells. So there are, again, numerous potentials with this as we're looking at this. Again, numbers of types or strains of this virus. So we may be looking at potentials for culprits for cancer, or possibly genital warts. There are numerous possibilities with this. And seeing these abnormal cells is definitely grounds for concern. Is that sort of okay? I'm gonna flip over to the textbook real quick, just to get a better image. Where is my OpenStax? Okay. Okay, so that was all the herpes. This table or this little micro connections, it is kind of interesting to see this, that, you know, a lot of STIs may go undetected, undiagnosed, asymptomatic, you don't recognize it. And it mentions in here HPV, looking at some of this stuff, baseline prevalence, 26.8% in women between ages of 14 to 59. That's a little bit concerning. Women aged 20 to 24, prevalence at 44%. That's also disturbing. And in these circumstances, a number have probably no idea that they're infected in the first place, right? So definitely something, you know, I feel like should be on your radar. So initially with this, the disease, cervical cancer, with our HPV, the human papillomavirus, and again, like I said, numerous types, 16 and 18 are the most common types of papillomavirus that result in cervical cancers. With that said, I mentioned there are other cancers as well. They could fit right within this category, but cervical cancer is definitely more common, all right? That's where we see, or elsewhere, all right? Transmission, direct contact, sexual contact, typically. So pap smears to diagnose, and then there are some vaccines, Gardasil and Cervarix vaccines. These vaccines are administered to both girls and boys, thinking pre-puberty, to ensure that they have been vaccinated and protected. And there is definitely promise with this as we think about the possibilities of, you know, those numbers that we just saw, to dramatically reduce those rates by vaccinating before we see children becoming sexually active in the first place. By providing this vaccine, definitely sets the stage to prevent specific cancers later in life. Gardasil initially was just for girls, and they later decided it should be for everybody. And so boys also being vaccinated, typically about 11 years old or so is when they start thinking about, you ought to get your first shot. How do I know that? Because I got some kids. So that's typically about where that stuff starts, and definitely provides a good leg up on preventing these potentials. So I highly recommend, if you've got children, that that's something that you consider getting them vaccinated against. Moving over to the next ones, here we're treating, we're not vaccinating, right? Like I said a minute ago, we don't have a cure for herpes, right? So genital herpes, here we can see type 1, type 2, typically thinking, as I said, the genital herpes are typically type 2, but it doesn't necessarily matter. And you can have, I think, upstairs, downstairs, and you can have the upstairs virus downstairs or vice versa. And it depends truly on what you're doing, all right? So there's definitely potentials with these guys once infected where you see recurring outbreaks. In some circumstances, it may be relatively mild, and in others, you can get definitely, as we saw the penis in a couple of slides back, obvious lesions that should be a flag that something's up, all right? So asymptomatic, definitely potentials with that, all right? So sexual contact or contact with open lesions sets the stage for becoming infected with those guys. Viral culture, PCR, and antibody detection with ELISA is a possibility with that. And then a couple antivirals to help deal with it, especially thinking during the process of a flare-up will help with that. But still contagious. The papillomas, human papilloma, there are, again, various strains with this, warts, genital warts. Other warts in other areas of the body are still papilloma viruses, different types, but same sort of an idea, all right? So contact with it, sexual contact if we're thinking genital warts. And in females, we get diagnosis with pap smear, as we showed those cells a second ago. The neonatal herpes, I already kind of mentioned this just a second ago. Again, either type and in transit through the birth canal or during gestation, they have the potential to become infected. So it just depends on circumstances, all right? And acyclovir is a treatment with that. All right, I think that's, let me stop this. Back to this guy. I've got so many things on here. Which one am I looking at? Okay. Maybe. All right, so shifting over from our viral culprits, we want to think a little bit about some fungi. Candida albicans is the culprit. There was a way back in the day when I was in grad school. There was a guy that we were lab mates. It is Candida. He called it Canada. It's not Canada. You know, blame Canada. No, it's not. Candida, right? Has nothing to do with Canada. If you've traveled up there, you didn't get infected, all right? It's not the same. All right. You know, we were studying fungus and his daughter contracted ringworm, and he calls me up and asks, what kind of worm is ringworm? I'm like, what the hell is your problem? You should know it's fungus. All right. But he was stuck in Canada, right? It's all good. All right, so Candida, these guys, as we look at this, we're looking at a handful of yeast cells, and some of them in the process of reproducing. So we can see these blastospores and chlamydiospores. So the blastospores, asexual, resulting from budding, which is how these yeast cells are reproducing. And then the chlamydiospores, these are resting spores, also asexual, all right, but a little bit different, all right. So it doesn't matter, you don't need to get bogged down with all of that stuff. The Candida does have the potential to produce these pseudohyphae, and it's kind of as it's in a process of growing and replicating that it pushes out these parts of their cell wall. It's not true hyphae. It's not, you know, hyphae we think about with molds, with filamentous fungi. These are yeast cells, but they produce structures that are reminiscent. They appear kind of like that under the microscope. Little careful examination, you can see that it's not long filamentous strands. It's connected to the yeast cell in the first place. And you'll see a image here in just a second that does a little bit better job of showing that stuff. So oftentimes, here's this formation, this little germ tube, and we might say, you know, looks microscopically as if it is hyphae, and it's not developing into hyphae, pseudohyphae, all right, is really what we should be saying here. It's not true hyphae, all right. So This yeast cell, here we've got a mother cell, here's a daughter cell that has budded off, and then this germ tube, this pseudohyphae that's starting to form, and potentially we'll see formation of a new daughter coming off of that shortly. All right. Oftentimes, when we think about candida infections, it's a result of your normal flora having some sort of imbalance, some sort of alteration to what's already going on that sets the stage for these yeast cells to proliferate, to really kind of take over. So you have you have some yeast cells as normal flora, all right? You kind of expect that you should see a little of that. In a healthy circumstance, seeing a little, not that big of a deal, all right? When you have some deviation from that, so maybe you're taking antibiotics, a broad spectrum antibiotic is a good one for setting the stage for this. Taking some antibiotics for some other issue can dramatically deplete your normal flora, and that sets the bacterial flora, sets the stage for the yeast cells that aren't targeted by those antibiotics to all of a sudden have ample real estate to proliferate, to colonize, and now we see yeast infection resulting from that. So there are potentials, again, as I said, yeast infection, we think in females, relatively common with antibiotic therapy to see these issues. There are other potentials where normal flora may be altered a little bit, and you can see yeast infection as well. So it doesn't have to just be antibiotics that sets the stage for that. We talked a little bit about like the bacterial vaginosis not a while back, it was with Monday. There's numerous things that set the stage to that, like hormone differences, so levels of estrogen fluctuating, approaching menopause, seeing those levels declining considerably. Oftentimes you may see the vaginosis, you may also see yeast infections as a result of that as well, as we see these alterations, right? So there are other potentials with that. You can see the candida being systemic, where it disseminates to other parts of the body. Prognosis with that is poor when that occurs. Oftentimes, patients that are immunologically very susceptible, so it could be maybe HIV or full-blown AIDS, setting the stage for candida to disseminate like that. There's other potentials. Little kids, oftentimes, we could see it in their mouth. We call it thrush. And it's kind of just, you kind of expect, when you've got a little kid and they're just kind of, getting in tune and picking up all sorts of organisms to populate them, that a little bit of thrush is probably going to be seen. So there are other possibilities. You can develop thrush later in life if, again, antibiotics are something that's an issue. I always share this story. I was high school age. I had a friend that got in an accident. He was paralyzed. He had an indwelling catheter. He technically was really supposed to not have that for the rest of his life, but he did. The issues with indwelling catheters, so he had a catheter that went right into his bladder and collected the urine into a bag attached to his leg. Issues with that, as you've got this open portal, bladder infections, pretty common, all right? You almost just guarantee. So he had all sorts of drugs that he had to take, and antibiotics were right in that regimen. He did not know at the time that taking a bunch of antibiotics set the stage for causing issues with his own flora, and he developed thrush. a pretty nasty bout of that. And a little bit later, figuring out what was up, he still taking antibiotics, started buying yogurt. It seemed like by the pallet, mass quantities of yogurt, because eating yogurt, probiotic, helps to alleviate those issues. So if you are prescribed antimicrobials, it's kind of a good idea to eat a little bit of yogurt as well. If you've got issues with that, there are other probiotics that you could think about that might help with that. So once he introduced the yogurt into his diet, issues with thrush basically went away. So kind of crazy. And I assume, you know, you'd see lots of yeast cells if you were to take a smear of that. So this next image shows kind of a normal and abnormal in green circumstance where we're looking at, I'm assuming probably another pap smear. So we've got lactobacilli, these little rods, gram-positive rods, and we've got an epithelial cell. There's a couple of them that are out of the frame, but one big one right here, all right? So epithelial cell and lots of lactobacilli, that's not bad news, all right? If we're thinking, you know, pap smear, there are numerous bacteria that colonize the vagina, and lactobacillus is one big player, all right? It helps to provide protection. It creates, as they are in there growing, it helps to create more of an acidic environment that becomes inhibitory to numerous organisms. Obviously not 100% effective, or we wouldn't be talking about any issues in the first place, all right? But as they colonize, as everything's all fine and good, they do set the stage that makes it relatively inhibitory for the candida to take hold and proliferate. When antibiotics are taken and the levels of lactobacilli are depleted considerably, then we set the stage for the next frame, for the candida to take over, and you get a big overgrowth of these yeast cells that sets the stage for, you know, what we were just talking about. So this, as we're looking at, this is a wet mount prepared with potassium hydroxide. That's the KOH. Potassium hydroxide, as it's added, a wet mount is where we're looking, we're not heat fixing this smear. We're looking at stuff that's still viable, still alive, all right? And the wet mount takes, as it's added, a drop of the potassium hydroxide is added to that wet mount. It takes the cells, the epithelial cells, and basically causes them to kind of degrade, allowing stuff that's other stuff to ultimately be visualized. It kind of cleans it up a little bit. Although I'm looking at this and I'm like, this seems like a much easier image to see, right? Here you've got all sorts of yeast cells, little spherical cells, and a lot of pseudo hyphae within there that over here, you can see some of these epithelial cells that have been kind of destroyed. Both vaginal samples, and in this case with B, someone that's with candidiasis. Shifting a little bit, I guess, we're still thinking eukaryotes, but from fungi to a protist. Trichomonas vaginalis is a pathogen that infects both females and males. Just because its species name is vaginalis doesn't mean that it's only found within the vagina, but you ought to assume that's one place that it would like to live, all right? So we've got a gram-stained specimen here. The vaginalis right here, huge compared to the bacterial cells that we can see, all right? A lot of these, my gut tells me probably some lactobacillus. Looks like nice purple rods, right? So there's some other stuff in there, maybe some cocci right here too, but it looks like a lot of rods, probably lactobacillus, all right? So Trichomonas vaginalis, these guys, little flagella right here. So flagellated protists, and they're kind of odd. All right. There are lots of parasites, lots of protozoal parasites, where the infection is transmitted by some sort of cyst. That's usually how protists get transmitted. But these guys don't have a cyst stage. So it's direct transmission. Oftentimes, sexual transmission sets the stage to share this with others because there is no cyst stage. So you need direct contact, all right? So these potentially asymptomatic in females, oftentimes they experience symptoms. In males, almost always asymptomatic infection. It sets the stage for some issues for sure. If the female recognizes this problem and gets diagnosed and receives treatment, if her partner does not, or partners do not receive treatment, the infection really isn't going to go away because she will be treated and then reinfected, right? So both partners need to be treated, even if one feels as if they are fine. They both need to be treated, right? And that ensures that the infection won't be reintroduced after the therapy is stopped. So it is something that is sexually transmitted, but there are other possibilities with this as well. They can be, sharing towels, sharing clothing, a washcloth. I teach a parasitology class that talks about this and mentions a washcloth that had remained moist at the bottom of the shower a day later, and someone infects themselves with that. My first thought is, who in the hell picks up a washcloth from the bottom of the shower and uses that? That's gross, all right? But it can happen, all right? So that should be right there. We should just stop and be like, I learned something today. Don't use dirty ass washcloths, right? Be all good, all right? It's hard to say, all right? There are, swimsuits for ladies. There is a little strip in the bottoms that really it's there to kind of help prevent this. You should wear your underwear as you're trying on swimsuits in the first place. But that little strip that's on there is supposed to kind of be a little bit protective, all right? I don't know, but maybe, all right? And it is relatively common. Like I said, definitely some issues with that, with the asymptomatic nature of it, where it sets the stage for it maybe to be easily spread, if you will. There are other concerns, and before I hit this, I think we're just about at the end of this. I think this is my last bit. Some of these infections that we've talked about are reportable diseases. So things that you get diagnosed and they, contact the health department and probably the CDC as well, and they share this information and they keep statistics about that, all right? Some people really like statistics, right? So they keep all this information, but there are other infections that are not reportable, all right? So the details with that maybe not as easy to really get a handle on when we think about possibilities, how much. Trichomonas is one that's non-reportable, all right? We have definite evidence of, issues with this and have some hints about numbers, but really with things that are non-reportable, you have to assume that those numbers are considerably greater. Especially thinking about people that are asymptomatic, all right? That's an issue in and of itself because they haven't been diagnosed because they don't know that there's any issues in the first place, all right? That's a potential issue. So last, as we hit this table, trichomoniasis from Trichomonas vaginalis, there's all sorts of potential issues with it as far as signs and symptoms. And again, typically it's going to be more pronounced in females than in males, all right? Urethritis, vaginal or penile discharge, more vaginal, all right? Redness, soreness of the female genitalia. Typically females know there's more going on, all right? Males, maybe a little bit of, you know, as it says here, maybe some discharge, but maybe a little bit of pain upon urination, maybe some burning, right? Maybe not, maybe nothing at all, right? And in turn, why would I go to the doctor? I feel fine, right? That's an issue. All right, so a couple of azoles as treatment for trichomoniasis. The candidiasis yeast infection is what we're hitting here because we are talking genitourinary tract, but similar sorts of ideas if we're thinking about other stuff, all right? So Candida albicans is one of the main culprits, but there are some other species that have the potential to set the stage for this, some that are of concern because treatment might be almost non-existent, and that's an issue with like drug resistance. So some issues with this, dysuria, vaginal burning, itching, and discharge. Typically, we think sexual as a potential with that to be transmitted, but it's also a possibility with disrupted flora that sets the stage for that. So, okay, and I think here I'm seeing exercise. Here's a little image of syphilis. What is it? I told you, too late. I'm going to quit here. I don't want to start the next one. We got a few minutes, but we'll stop a little bit short. I think that's fine. Any questions or concerns? Seeing nothing on my chat. Okay, guys. I will see you all on Friday. We'll start the next chapter. Have a great day. It looks like it's going to be nice out there. You should call it a day and just enjoy the outside.